Now listen carefully, we're going to break down different types of observational studies in public health sciences, especially in the fields of epidemiology and biostatistics. Let's start with a case series. This type of study simply describes several individuals who have the same diagnosis, treatment, or outcome. It's mostly about describing clinical findings and symptoms. But here's something important: you should remember that a case series does not include a comparison group, and because of that, it can't show whether a specific risk factor is actually linked to the disease. Now let's talk about the cross-sectional study. This one looks at a population at a single point in time. It asks, what is happening right now? It assesses both the frequency of a disease and the frequency of risk-related factors at the same time. While it can show an association between a risk factor and a disease, it doesn't prove causality, which means we can't say that one thing caused the other. But it's still useful for understanding prevalence, or how common a disease is in a population. Are you following me? Good. Now, let's move on to the case control study. This one is a bit different because it's retrospective, which means it looks back in time. It compares a group of people who already have a disease to a group who don't. The main question here is, what happened in the past? Specifically, it tries to see if the odds of having been exposed to a certain risk factor differ between the two groups. The key measurement here is the odds ratio, often called the OR. For example, patients with COPD were found to have higher odds of having a smoking history than those without COPD. Just remember this phrase: control the case in the OR, meaning you compare the cases and controls using the odds ratio. Now let's move forward to the cohort study. This type compares people who have a particular exposure or risk factor to people who don't. And then it watches what happens, whether they go on to develop the disease. It can be done prospectively, meaning looking forward in time, or retrospectively, using past records. But here's the key: the risk factor must be present before the disease develops. This study focuses on disease incidence, and its main measure is called relative risk, or RR. For instance, people who smoke had a higher risk of developing COPD than those who didn't. So, always remember, cohort equals relative risk. You should also remember some special types of observational studies. A twin concordance study, for example, compares how often both twins, either monozygotic, meaning identical, or dizygotic, meaning fraternal, develop the same disease. This helps us understand whether genetics or the environment plays a bigger role. It's the classic nature versus nurture question. And then there's the adoption study, which looks at how behavioral traits or genetics differ in siblings who were raised by biological parents compared to those raised by adoptive parents. Again, this helps measure how much genetics or environment influence health outcomes. Finally, let's talk about the ecological study. This one compares the frequency of disease and risk-related factors across whole populations, not individuals. It's used to monitor public health at the population level. But be careful, just because two things are associated at the group level doesn't mean they're linked in individuals. That mistake is called the ecological fallacy. For example, COPD might be more common in cities with more pollution, but we can't say for sure that every person with COPD lived in a polluted area. Now let's tie it all together with a timeline. Imagine time moving from the past to the future. A cross-sectional study happens in the present. It compares disease prevalence and risk factors at the same time. A case control study looks into the past, comparing those with the disease to those without, and asks about past exposures. Then, a cohort study, whether it's retrospective or prospective, tracks disease incidence by comparing exposed and unexposed groups over time. Now listen carefully, we're diving into the world of clinical therapeutic trials, which are a key part of experimental studies involving humans. These trials are designed to compare the therapeutic benefits of two or more interventions, for example, comparing a treatment to a placebo, or one treatment to another. You should remember that the quality of a clinical trial improves when it's randomized, controlled, and double-blinded. That means neither the participant nor the researcher knows who is in the treatment group or the control group. And when we say triple-blinded, it means the data analysts are also blinded to the group assignments, so even they don't know who got what until after the data is fully analyzed. Now let's talk about a special type called a crossover clinical trial. In this design, each subject receives a series of treatments, but the order is randomized. There's also a washout period between treatments to make sure the first drug doesn't affect the second. The great thing here is that each subject serves as their own control, which helps reduce variability. Are you following me? Good, because now we're going to explore how the data is analyzed. First, there's intention to treat analysis. This means that all subjects are analyzed based on the treatment they were originally assigned, no matter what actually happened later. So, even if they dropped out or switched treatments, they're still included in their original group. This approach helps reduce bias from people leaving the study or not following the plan, though it might dilute the treatment's true effect. Then we have as-treated analysis, which analyzes people based on the treatment they actually received, not what they were assigned. But be careful, this increases the risk of bias. And finally, per-protocol analysis only includes those who stuck to the plan. It excludes anyone who didn't follow through with their assigned treatment. Again, this can increase bias. Now, are you ready to go through the phases of a clinical trial? Before trials start in humans, we begin with preclinical studies, where the drug is tested on animals and in lab experiments to check for basic safety and function. After that, we enter phase 0. This is a small, early study that uses microdoses to get a quick look at how the drug behaves in the body. It's often skipped, but when used, it involves a very small number of healthy volunteers or patients and is open label, meaning everyone knows what's being given. Next comes phase 1, where we focus on safety. Here, we gradually increase the dose to find out the maximum tolerable level. This phase includes a small group of healthy volunteers or sometimes patients, and it's also typically open label. Now listen carefully, phase 2 steps things up. We bring in a moderate number of patients who actually have the disease we're targeting. This phase is randomized, controlled, and anonymized. The goal here is to answer the question, does it work, and to gather more information about short-term side effects. Then we move to phase 3, which involves a large number of patients. Like phase 2, it's randomized, controlled, and anonymized, but now we're testing effectiveness. We want to know, does this new treatment actually improve outcomes compared to the current standard of care or a placebo? After that, we reach phase 4, which happens after the drug is approved and out on the market. This is called post-marketing surveillance. It provides data on long-term safety and rare adverse effects. And remember, phase 4 answers the question, can it stay on the market? By the way, there's a helpful acronym to remember the phases, can I swim? That stands for, can equals preclinical, I equals phase 0, small sample, S equals phase 1, safety, W equals phase 2, does it work, I equals phase 3, any improvement, M equals phase 4, market surveillance. Now let's switch gears and talk about off-label drug use. This means using a drug to treat a disease, a population, or a dosage form that hasn't been specifically approved by the FDA. Doctors might try off-label use when no approved treatment exists, or when the standard options have failed. For example, tricyclic antidepressants, originally made for depression, are often used off-label to treat neuropathic or chronic pain. Do you know the Bradford-Hill criteria, which are used to evaluate whether there's a causal relationship between a risk factor and an outcome? These principles don't guarantee causation, but they support it. Let's go through them quickly. Strength refers to the size of the association, the stronger it is, the more likely it's causal. Consistency means the same results are found across different studies. Regarding specificity, the more specific the presumed cause is to the effect, the stronger the evidence for causation. Temporality means the cause comes before the effect, as it should. Biological gradient shows a dose-response relationship, the more exposure, the greater the effect. Plausibility means there's a believable mechanism. Coherence means the findings don't conflict with what we already know scientifically. Experiment is when empirical evidence supporting the presumed cause and effect, e.g., animal studies, in vitro studies. And analogy is when the presumed cause and effect are comparable to a similar, established cause and effect. Now listen carefully, we're going to go through some core statistical measures used in epidemiology and biostatistics. Let's start with the odds ratio, often abbreviated as OR. This is typically used in case control studies, and it represents the odds of exposure among cases, that's A over C, compared to the odds of exposure among controls, that's B over D. When OR equals 1, it means the odds of exposure are equal in both cases and controls. When OR is greater than 1, it means the odds of exposure are greater in the cases. And if OR is less than 1, the odds of exposure are greater in the controls. For example, in a case control study, if 20 out of 30 patients with lung cancer, and 5 out of 25 healthy individuals, report smoking, the OR is 8. This means patients with lung cancer are 8 times more likely to have a history of smoking. And don't forget this memory trick, you take a case to the OR. Now, the formula for odds ratio is, A over C, divided by B over D, which simplifies to, A times D over B times C. Now let's talk about relative risk, or RR, which is typically used in cohort studies. This tells us the risk of developing disease in the exposed group, divided by the risk in the unexposed group. When RR equals 1, it suggests no association between exposure and disease. When RR is greater than 1, the exposure is associated with increased disease occurrence. And when RR is less than 1, the exposure is associated with decreased disease occurrence. Now listen carefully, if 5 out of 10 people exposed to radiation are diagnosed with cancer, and 1 out of 10 people not exposed are diagnosed with cancer, then RR is 5. That means people exposed to radiation have a 5 times greater risk of developing cancer. And remember, for rare diseases with low prevalence, the odds ratio approximates the relative risk. The formula is, A over A plus B, divided by C over C plus D. Now let's move to relative risk reduction, or RR. This is the proportion of risk reduction attributable to the treatment, also called ART, compared to the control, known as ARC. For example, if 2% of vaccinated patients develop the flu, while 8% of unvaccinated patients develop it, then RR is 2 over 8, which equals 0.25. So, RRR is 1 minus RR, which gives you 0.75. Alternatively, RRR can also be calculated as ARC minus ART, divided by ARC. Now listen carefully, attributable risk, or AR, is the difference in risk between exposed and unexposed groups. Let's say the risk of lung cancer in smokers is 21%, and in non-smokers it's 1%. The attributable risk is the difference, 21% minus 1%, which equals 20%. The formula is, A over A plus B, minus C over C plus D. You can also calculate AR percent using RR minus 1, divided by RR, times 100. Next, we have absolute risk reduction, or ARR. This is the difference in risk, not the proportion, attributable to the intervention, as compared to a control. For instance, if 8% of people who receive a placebo get the flu, and only 2% of those who receive the flu vaccine get it, then ARR is 8% minus 2%, which is 6%, or 0.06. The formula is, C over C plus D, minus A over A plus B. Now let's talk about number needed to treat, abbreviated as NNT. This tells us how many patients need to be treated for one person to benefit. A lower number means a better treatment. And the formula is simple, NNT equals 1 over ARR. In contrast, number needed to harm, or NNH, tells us how many patients need to be exposed to a risk factor for one person to be harmed. And here, a higher number means safer exposure. The formula is, NNH equals 1 over AR. Finally, let's cover the case fatality rate, or CFR. This is the percentage of deaths occurring among those diagnosed with a disease. For example, if 4 patients die out of 10 cases of meningitis, the case fatality rate is 40%. The formula is, deaths divided by cases, times 100. Now listen carefully, let's begin with the mortality rate. This is the number of deaths, either in general or from a specific cause, within a population over a defined period of time. For example, if 80 people in a town of 10,000 die over 2 years, the mortality rate is 4 per 1,000 per year. In formula terms, it's deaths per 1,000 people per year. Now let's talk about the attack rate. This is the proportion of exposed people who become ill. For example, if 80 people in a town are exposed to an infection and 60 of them become ill, the attack rate is 60 over 80, which equals 75%. The formula is, people who become ill, divided by the total number of people exposed. Now are you following me? Good, because now we're talking about demographic transition. As a country develops and reaches higher levels of economic and health progress, both birth rates and mortality rates decline, though at different stages. This transition gradually changes the age composition of the population. Let's now visualize this through a population pyramid. Imagine horizontal bars, separated by sex, with age groups on the vertical axis. In countries with a high birth rate and high mortality rate, the pyramid is wide at the bottom and narrow at the top, indicating a growing population. Life expectancy here is short. As birth and death rates decrease, the pyramid becomes more even. This reflects a stable population with longer life expectancy. And finally, in declining populations, the base narrows, and the top becomes wider, meaning birth rates have dropped below replacement level and the population is aging. Now let's move into the likelihood ratios, often written as LR. These are used to interpret diagnostic test results. Let's start with LR positive. It equals the probability of a positive result in someone who has the disease, divided by the probability of a positive result in someone who does not have the disease. In other words, sensitivity over 1 minus specificity. This is also known as the true positive rate divided by the false positive rate. Now listen carefully, LR plus values greater than 10 indicate a highly specific test. Now let's talk about LR negative. It equals the probability of a negative result in someone who has the disease, divided by the probability of a negative result in someone who does not have the disease. In formula terms, it's 1 minus sensitivity over specificity. That means false negative rate divided by true negative rate. LR minus values less than 0.1 indicate a highly sensitive test. And don't forget this, pre-test odds multiplied by likelihood ratio gives you the post-test odds. Then to convert that to a probability, you divide post-test odds by post-test odds plus 1. Now let's finish strong with the Kaplan-Meier curve, which is used to estimate the probability of survival over time. This is a graphical representation with survival probabilities on the vertical axis and time on the horizontal axis. This method is useful for analyzing time-to-event data, where the event can be anything, but most commonly it refers to mortality. The survival probability at any time is calculated as 1 minus the event probability. To compare survival between groups, the p-value for survival difference can be calculated using either a log-rank test or a Cox regression model. Now listen carefully, when we talk about evaluating diagnostic tests, we begin with this important point: sensitivity and specificity are fixed properties of a test. But positive predictive value and negative predictive value can vary depending on the disease prevalence in the population being tested. Now let's talk about test efficiency. This is calculated as the number of true positives plus true negatives, divided by the total number of all test outcomes. That means, true positives plus true negatives, over the sum of true positives, false negatives, and true negatives. Are you following me? Good. Now picture the classic 2 by 2 table, with test results across the top and disease status on the side. Let's define the formulas. Sensitivity is equal to true positives divided by true positives plus false negatives. In other words, it's the proportion of people with the disease who test positive. You can also express it as 1 minus the false negative rate. It is the ability of a test to correctly identify those with the disease. Value approaching 100% is desirable for ruling out disease and indicates a low false negative rate. Now remember this clue, SNN out. A highly sensitive test, when negative, rules out the disease. That's why high sensitivity tests are ideal for screening. Now let's move to specificity. It's equal to true negatives divided by true negatives plus false positives. This tells you the proportion of people without the disease who test negative. You can also write it as 1 minus the false positive rate. It is the ability of a test to correctly identify those without the disease. Value approaching 100% is desirable for ruling in disease and indicates a low false positive rate. And here's your clue, SPPIN. A highly specific test, when positive, rules in the disease. That's why high specificity tests are used for confirmation, especially after a positive screening test. Now we'll shift to positive predictive value, or PPV. This is the probability that a person with a positive test result actually has the disease. PPV is calculated as true positives divided by true positives plus false positives. PPV varies directly with the pretest probability, which depends on disease prevalence. So, higher prevalence means higher PPV. Let's now look at negative predictive value, or NPV. This is the probability that a person with a negative test result actually does not have the disease. NPV is calculated as true negatives divided by true negatives plus false negatives. NPV varies inversely with disease prevalence, so as prevalence increases, NPV goes down. Now listen carefully, let's review cutoff values. These influence test performance. Imagine 3 cutoff points labeled A, B, and C. Cutoff A gives you 100% sensitivity, but may allow more false positives. Cutoff C gives you 100% specificity, but may allow more false negatives. Cutoff B is a practical compromise, balancing sensitivity and specificity. Now, lowering the cutoff point, for example moving from B to A, increases sensitivity and increases NPV, but also increases false positives and decreases specificity and PPV. On the other hand, raising the cutoff, such as moving from B to C, increases specificity and PPV, but also increases false negatives and decreases sensitivity and NPV. Are you ready for a special case? In diseases where the diagnosis is based on lower values, like anemia, the graph flips. So, higher sensitivity actually means fewer true positives, and the roles of TP and TN are switched in that context. Now let's finish with the receiver operating characteristic curve, or ROC curve. This curve helps us evaluate how well a diagnostic test can distinguish between two groups, those with disease and those who are healthy. The ROC curve plots the true positive rate, which is sensitivity, against the false positive rate, which is 1 minus specificity. A better performing test will have a curve that moves closer to the upper left corner of the graph. The area under the curve, or AUC, tells you how good the test is. An ideal test has an AUC of 1. A test with no predictive value has an AUC of 0.5. Most real tests fall somewhere in between, meaning the area under the curve is greater than 0.5 but less than 1. Now listen carefully. Precision, also known as reliability, is the consistency and reproducibility of a test, which means it's the ability to produce similar results over repeated trials, and it reflects the absence of random variation. When there's more random error, the precision of the test decreases, but when precision increases, the standard deviation becomes smaller, and higher precision also leads to greater statistical power, which is defined as 1 minus beta. On the other hand, accuracy, or validity, refers to how close test results are to the actual true values, and it depends on the absence of systematic error or bias in the test. So, if there's systematic error, accuracy will decrease, and depending on the combination of these two, a test can be highly accurate and highly precise, which is ideal, or it might be highly precise but not accurate, meaning results are consistent but wrong, or it might be accurate but not precise, meaning the values vary widely but average out close to the truth, and in the worst-case scenario, The test can be both inaccurate and imprecise. Now let's talk about incidence versus prevalence. Incidence looks at new cases, just think of incidents happening, while prevalence looks at all current cases whether they are new or old. Specifically, incidence is the number of new cases over a unit of time divided by the number of people at risk, and it measures how fast new cases are appearing. Prevalence, however, is the number of existing cases at a specific point in time, divided by the total number of people in the population, and it tells us how widespread a disease is. You should remember this: prevalence equals incidence multiplied by the average duration of disease, so when a disease lasts longer, prevalence increases significantly, and this is why in chronic diseases like diabetes, prevalence is much higher than incidence. Also, prevalence is roughly equal to the pretest probability, and as prevalence goes up, positive predictive value increases while negative predictive value decreases. However, in diseases that last only a short time, such as the common cold, prevalence is approximately equal to incidence. Are you following me? Let's now explore how different scenarios can affect both incidence and prevalence. If survival time increases, then prevalence will increase because people live longer with the disease. But if the mortality rate rises, then prevalence goes down since people are dying sooner. Similarly, if people recover faster, prevalence will also decrease. Now, if a country introduces widespread vaccination, both incidence and prevalence will decrease due to fewer new cases and better prevention. However, if risk factors decrease, both incidence and prevalence go down because more people are at risk. If the diagnostic sensitivity improves, meaning we detect more cases, then both incidence and prevalence will increase as well. When a new effective treatment is introduced, prevalence may drop as patients are either cured or better managed, but incidence is not affected. And finally, when there's a reduction in contact between infected and uninfected individuals, especially for airborne diseases, both incidence and prevalence will decrease. Now listen carefully: when we talk about bias and study errors, we have to start with selection bias, which occurs when subjects are chosen through non-random sampling or treatment allocation, so that the study population is no longer representative of the target population. This is most commonly a sampling bias, and examples include convenience sampling, where patients are enrolled just because they are easy to contact, or Berkson bias, where cases and controls selected from hospitals, often called bedside bias, end up being less healthy and having different exposures compared to the general population. There's also attrition bias, where participants who drop out of a study have a different prognosis than those who stay and complete it. To reduce these types of bias, researchers should use randomization, which helps create groups with similar distributions of both known and unknown variables, and they must also choose the right comparison or reference group carefully. Are you following me? Next, while performing the study, one common problem is recall bias, which happens when subjects' awareness of a disorder alters how they remember past exposures. This is especially common in retrospective studies. For example, a patient with a disease might remember an exposure more clearly after learning that similar cases exist. To reduce recall bias, it's helpful to decrease the time from exposure to follow-up, and when possible, to use medical records instead of relying on memory. Another issue is measurement bias, where information is collected in a distorted or inconsistent manner. This might happen if a faulty device like an automatic sphygmomanometer is used, or if participants change their behavior because they know they are being observed, something called the Hawthorne effect, where people act differently when they feel watched, just like a hawk. To avoid this, researchers should plan ahead and use objective, standardized, and previously tested methods of data collection, and they should also consider including a placebo group. Then there's procedure bias, which happens when subjects in different groups are not treated the same. Say, for instance, if patients in the treatment group spend more time in specialized hospital units. Blinding, or masking, and the use of a placebo can help here by reducing the influence of both participants and researchers on how the procedures are carried out or how outcomes are interpreted, because neither group knows who's receiving which treatment. Observer expectancy bias is another subtle but powerful source of error, where the researcher's belief in a treatment influences the outcomes they record. This is also known as the Pygmalion effect, so if an observer expects the treatment group to improve, they might be more likely to document positive results. Now let's talk about interpreting results. Lead time bias can happen when early detection is confused with increased survival, even though the actual disease course hasn't changed. For instance, diagnosing breast cancer early using mammography might seem to increase survival time, but that's only because patients are known to have the disease for longer, not because they live longer. To deal with this, one should measure back-end survival, adjusting survival time based on the severity of disease at diagnosis, although this method may mask potential causality. There's also length time bias, where screening tests are more likely to detect diseases that progress slowly and have long latency periods, while fast-growing diseases become symptomatic too quickly to be caught by routine screening. For example, a slowly progressing cancer is more likely to be found by screening than a fast-moving one. The best way to minimize this kind of bias is by conducting randomized controlled trials that assign subjects either to a screening program or to no screening at all, so the results can be compared properly and fairly. Now listen carefully, because it's very important to understand the difference between confounding and effect modification. Confounding happens when a factor is related to both the exposure and the outcome, but it's not on the direct causal pathway. This factor ends up distorting the perceived relationship between exposure and outcome. A classic example is when coffee seems to be linked to lung cancer, but in reality, it's smoking that's the real cause, because people who drink coffee are more likely to smoke. When we perform stratified analysis, meaning we separate the data into groups, such as smokers and non-smokers, the association between coffee and lung cancer disappears, revealing that it was confounded by smoking. To reduce confounding, researchers can use crossover studies where the same subject serves as their own control, or they can use matching, which involves selecting patients with similar characteristics for both the treatment and control groups. They can also apply analytical techniques like regression analysis, especially when the confounding variables are already known and have been measured. Now let's shift gears to effect modification, which is a totally different concept. Effect modification happens when the exposure leads to different outcomes in different subgroups of the population, so the effect truly varies depending on another factor. Unlike confounding, this is not a distortion, but a real interaction. For instance, a study might find that oral contraceptive pill, OCP, use is associated with deep vein thrombosis, or DVT. But when the data is stratified by smoking habits, we may find that there's a strong association between OCP use and DVT in smokers, while no such association exists in non-smokers. This is a true effect modification, because the effect of OCP on DVT genuinely differs depending on whether or not the woman smokes. The best strategy here is stratified analysis. After checking for interaction between factors like OCP use and smoking, the researcher then analyzes the risk separately in smokers and non-smokers. So, to sum it up, confounding is when a hidden factor creates a false association that vanishes once you adjust for it, while effect modification is when the association is real but changes in strength or direction depending on subgroups. In simple terms, in confounding, the crude analysis shows an association that disappears after stratification, but in effect modification, stratified analysis reveals that one group shows a strong effect while the other shows little or none, and both findings are real. Are you following me? Now listen carefully, because understanding statistical distributions is essential for interpreting research results accurately. Let's start with the measures of central tendency, which help describe the center of a data set. The mean is calculated by adding up all the values and dividing by the total number of values. However, the mean is the most affected by outliers or extreme values. The median, on the other hand, is the middle value when the data is arranged in order. If the data set has an even number of values, then the median is the average of the two middle numbers. And then there's the mode, which is simply the most frequently occurring value in a data set, and it is the least affected by outliers. Now let's talk about measures of dispersion, which describe how spread out the values are. The standard deviation tells us how much variability exists around the mean, while the standard error estimates how much variability would be expected in a set of sample means around the true population mean. The formula for standard error is the standard deviation divided by the square root of the sample size, meaning SE decreases as the sample size increases. Remember, variance is just the square of the standard deviation. Are you still with me? Good, now let's move on to the normal distribution, also known as the Gaussian or bell-shaped distribution. In a perfectly normal distribution, the mean, median, and mode are all equal. It's symmetric, and most values fall close to the mean. Specifically, about 68% of the data falls within one standard deviation, 95% within two, and 99.7% within three. But not all data sets follow this pattern. In bimodal distributions, there are two distinct peaks, suggesting two separate populations, like fast and slow acetylators or differences in age at onset of a disease. When data is skewed, the shape changes. In a positively skewed distribution, the tail is longer on the right, and the mean is greater than the median, which is greater than the mode. Meanwhile, in a negatively skewed distribution, the tail is longer on the left, and the mean is less than the median, which is less than the mode. In these cases, the median is usually a better indicator of central tendency than the mean. Now let's turn to statistical hypothesis testing. The null hypothesis, also called H0, is the assumption that there is no difference or no association, for example, no relationship between a disease and a risk factor. The alternative hypothesis, or H1, proposes that there is some kind of association or difference. The p-value plays a key role here. It tells us the probability of observing our results, or more extreme ones, just by chance, assuming the null hypothesis is true. If the p-value is less than 0.05, we often say the result is statistically significant, meaning there's less than a 5% chance that the observed result happened randomly. So you should remember this, p-values don't prove a hypothesis, they only suggest how consistent the data is with the assumption that there's no real effect. Now listen carefully, when it comes to outcomes of statistical hypothesis testing, a correct result can mean one of two things: either the study correctly states that there is an effect or difference when one truly exists, which means the null hypothesis, H0, is rejected in favor of the alternative, H1, or it correctly states that there is no effect or difference when none exists, meaning H0 is not rejected. So, in terms of reality, if H1 is true and the study rejects H0, that's a correct decision, and if H0 is true and the study does not reject it, that's also a correct conclusion. But when the study rejects H0 when it's actually true, that's called type 1 error, also labeled alpha, and when the study fails to reject H0 even though H1 is true, that's type 2 error, or beta. On the other hand, when H1 is true and H0 is rejected, that reflects the power of the test, which is 1 minus beta, and when H0 is true and not rejected, that simply confirms H0. So the blue shading in a hypothesis outcome chart indicates the correct results. Now let's talk about testing errors, and listen closely. A type 1 error, also known as alpha, occurs when we state that there is an effect or difference, even though in reality, there is none. This means H0 is incorrectly rejected in favor of H1. Alpha represents the probability of making this type of error, and usually, 0.05 is chosen. So if the p-value is less than alpha, then assuming that H0 is actually true, the probability of obtaining such extreme test results would be less than 5%, which leads us to reject H0 as unlikely. But remember, statistical significance does not equal clinical significance. Type 1 error is also called a false positive error, and here's a helpful story. The first time the boy cries wolf, the town believes there is a wolf, but there really is not. That's a false alarm, a false positive, or a type 1 error. And just to be clear, you can never prove that H1 is absolutely true, but you can reject H0 as being very unlikely. Now are you following me? Let's move on to type 2 error, also known as beta. This error happens when we say that there is no effect or difference, when in fact, one does exist. This means H0 is not rejected when it actually should be. Beta is the probability of making this mistake, and it is directly related to the statistical power, which is 1 minus beta, meaning, the probability of correctly rejecting H0 when it is false. You can increase power and reduce beta by increasing the sample size, increasing the expected effect size, improving the precision of your measurements, or raising the alpha level, which increases the statistical significance threshold. Type 2 error is also called a false negative error, and here's another helpful story. The second time the boy cries wolf, the town doesn't believe him, but this time, the wolf is actually there. That's a false negative. So if you increase the sample size, you increase the power, because remember, there is power in numbers. And keep this in mind, generally, when type 1 error increases, type 2 error decreases, and vice versa. Now listen carefully to this last part. The difference between statistical significance and clinical significance is very important. Statistical significance is defined by how likely it is that the study results occurred by chance. A high statistical significance means a low probability that the results are due to random variation. But clinical significance focuses on the actual impact of an intervention on patient outcomes. It tells us whether the change is meaningful in real life. Some studies may show very high statistical significance, but the intervention itself may have limited clinical importance. For example, a study might show a statistically significant reduction in blood sugar levels by just 1 mg per deciliter, and while that's statistically real, it may not make a big difference clinically. So always ask, is the result just statistically true, or is it also meaningful for the patient? Now let's talk about confidence intervals. A confidence interval is simply a range of values within which the true mean of the population is expected to fall, and this is done with a specified level of probability. For example, when we say Ci equals 1 minus alpha, it means that a 95% confidence interval corresponds to an alpha level of 0.05. This 95% Ci is very commonly used in research. And as your sample size increases, the confidence interval actually becomes narrower, meaning we become more confident about the estimated range. The confidence interval for a sample mean is calculated as x bar plus or minus z times the standard error, and here, z is a constant that changes based on the level of confidence we want. For a 95% confidence interval, z is 1.96, and for a 99% confidence interval, z is 2.58. Now listen carefully, we reject the null hypothesis, and consider the result statistically significant, when the 95% confidence interval for the mean difference excludes 0, or when the 95% confidence interval for an odds ratio or a relative risk excludes 1, or if the confidence intervals between two groups do not overlap. On the other hand, we do not reject the null hypothesis, and say that the results are not statistically significant, when the 95% confidence interval for the mean difference includes 0, or when the odds ratio or relative risk includes 1, or if the confidence intervals between two groups do overlap. So always remember, exclusion of 0 or 1 tells us the result is significant, while inclusion means it is not. Now let's talk about meta-analysis, which is a powerful method of statistical analysis that actually combines or pools together summary data, like means or relative risks, from multiple different studies, all in order to get a more precise estimate of the true size of an effect. Not only that, it also helps us estimate the heterogeneity, or variability, of effect sizes between studies. Meta-analysis improves the statistical power, strengthens the overall level of evidence, and boosts the generalizability, also known as external validity, of study findings. But keep in mind, its strength is still limited by the quality of the individual studies it includes, and also by any bias in how studies were selected. Now listen carefully, because we're going into the common statistical tests, and each one has its own specific use. First, we have the t-test, which is used to check the differences between the means of two groups. A fun way to remember this is by thinking, t is meant for 2. For example, if you are comparing the mean blood pressure between men and women, the t-test is what you'd use. Then we have ANOVA, which stands for analysis of variance, and this is used when you want to check the differences between the means of 3 or more groups, and just think of the 3 words in its name to remember this. For example, if you're comparing the mean blood pressure among 3 different ethnic groups, then ANOVA is the way to go. Now let's move on to the chi-square test, written as the Greek letter chi followed by a square. This test is used when you're comparing two or more percentages or proportions for categorical outcomes, not mean values. A good way to remember it is to pronounce it as categorical, to link it to categorical variables. For instance, if you're comparing the proportion of people in 3 different age groups who have essential hypertension, this is the test you'd use. However, when you're working with small samples, especially for categorical, nominal outcomes, the better option is the Fisher's exact test. It's the preferred alternative to the chi-square test when sample sizes are limited. For example, if you're comparing the percentage of 20 men and 20 women with hypertension, Fisher's exact test is more accurate. Finally, let's summarize how to choose between these tests depending on your data type and situation. If you're comparing numerical means, and you have 2 groups, you use a t-test. If you have 3 or more groups, go with ANOVA. But if your data involves categorical proportions, then it's either chi-square or Fisher's exact test, with Fisher's being best for small sample sizes, and chi-square better for large samples. Now let's talk about the Pearson correlation coefficient. This is a measure of the linear correlation between 2 variables, and it's usually denoted by the letter R. The value of R always falls somewhere between -1 and +1, and the closer the absolute value of R is to 1, whether it's positive or negative, the stronger the linear relationship between the 2 variables. Now listen carefully, because understanding R is key. A positive R value indicates a positive correlation, which means that as one variable increases, the other one also increases. On the other hand, a negative R value shows a negative correlation, which means that as one variable increases, the other one decreases. You should also remember the concept of variance, which tells us how much the measured values differ from the average value in a data set. And here's something important: the coefficient of determination, which is R squared, tells us the proportion of variance in one variable that can actually be explained by the variance in the other variable. But be careful, even if the correlation is strong, it doesn't necessarily mean that one variable causes the other. So remember, correlation does not imply causation. Now are you ready for some examples? If R equals 0, that means there is no correlation at all. If R is positive 0.4, that indicates a weak positive correlation, while negative 0.4 suggests a weak negative correlation. If R is positive 0.8, we call that a strong positive correlation, and if R is negative 0.8, then it's a strong negative correlation. So whether the correlation is weak or strong, positive or negative, just remember that the closer R gets to 1 or -1, the stronger the linear relationship becomes. But again, even strong correlation doesn't mean there's a cause and effect relationship. Let's dive into public health sciences and ethics, beginning with the core ethical principles. First, we have autonomy, which refers to the obligation to respect patients as unique individuals. This includes telling the truth, maintaining confidentiality, and creating the right conditions so patients can make informed choices. It also means honoring their decision, whether they choose to accept or refuse medical care. Next is beneficence, which simply means, do good. Physicians have a special ethical duty, known as a fiduciary duty, to act in the best interest of the patient. But sometimes this principle may clash with autonomy. For instance, an informed patient may choose something contrary to medical advice, or it may conflict with the greater good of society, like requiring treatment for tuberculosis. However, tradition holds that what's best for the patient should come first. A related idea here is the principle of double effect, which means that when caring for a dying patient, doctors prioritize comfort, even if the treatment might have side effects, like respiratory depression from opioid use. Then comes non-maleficence, which means, do no harm. This must always be balanced with beneficence. If the benefits clearly outweigh the risks, a patient can make an informed choice to go ahead, and that includes many surgeries and medications. Lastly, we talk about justice, which is about treating everyone fairly and equitably. But remember, fair does not always mean equal. For example, in situations like triage, patients are prioritized based on the severity of their condition, not on who arrived first. Now let's talk about decision-making capacity, which is a key part of ethical care. A physician must assess whether the patient is both psychologically and legally able to make a particular healthcare decision. It's important to understand that decisions made while a person has capacity don't automatically get reversed if they lose that capacity later. Also, having an intellectual disability or a mental illness doesn't mean someone can't decide. What matters is whether the current condition is affecting their ability to think clearly and make a choice right now. Capacity is evaluated by a physician and is specific to each medical decision, like choosing to refuse surgery. On the other hand, competency is a broader legal determination made by a judge, often relating to all healthcare-related decisions. There are 4 key elements in assessing a person's decision-making ability. First is understanding, where the person should be able to describe what they know about their illness and the proposed treatment. Then comes appreciation, which involves recognizing how the illness affects them personally and understanding why the doctor recommends a certain treatment. Third is reasoning, which involves weighing the options carefully. And finally, there's expressing a choice, where the person can clearly state what they want to do. Are you ready to go deeper? Let's explore informed consent. This is not just a signature on paper, it's a thoughtful process. It begins with disclosure, which means the healthcare provider shares all relevant information, including risks and benefits, and uses an interpreter if needed. Then, the patient needs understanding, which means they actually grasp what was shared. They also need capacity, meaning they can think clearly and make decisions for themselves. And finally, voluntariness, meaning they are choosing freely, without pressure or manipulation. Patients must fully understand their diagnosis, all the treatment options, including the benefits, the risks, and even what happens if they do nothing at all. They also have the right to withdraw consent at any time, and yes, even saying it out loud is enough to cancel it. Now listen carefully, there are some exceptions to informed consent, and here's an easy way to remember them: just wipe it away. W stands for waiver, where a patient willingly gives up their right to be informed. I stands for being legally incompetent, which means the patient can't make their own medical decisions, and so a legal surrogate must be involved. P is for therapeutic privilege, when a doctor holds back information if revealing it would seriously harm the patient or disrupt their ability to decide. And E is for emergency, where there's no time to get consent, so it's assumed. Now let's discuss consent when it comes to minors. A minor is typically anyone under the age of 18, and in most cases, parental consent is required. But there are some important exceptions. If it's an emergency, like needing a blood transfusion, consent may not be necessary. And if the minor is legally emancipated, say, they're married, financially independent, or serving in the military, then they can make their own healthcare decisions. Also, in specific situations, parental consent is usually not required. These include care related to sexual health, like contraception, sexually transmitted infections, or prenatal care, though abortion laws vary. It also includes treatment for substance use disorders, and care in emergencies or trauma cases, what you might remember as sex, drugs, and rock and roll. Still, doctors are encouraged to promote open and healthy communication between minors and their guardians. Even when legal consent isn't needed, physicians should try to obtain the minor's assent, which means getting their agreement and involving them in the decision. Now let's wrap up with advance directives, which are instructions a patient gives in case they're unable to make decisions later. These instructions vary depending on state laws. An oral advance directive is based on things the patient said before they became incapacitated. These can be tricky, since people may remember things differently. But if the statements were clear, made multiple times, and shared with different people, they are considered more reliable. A written advance directive, such as a living will, gives specific directions about what kind of treatments the patient would accept or reject during serious illness. There's also something called medical power of attorney, where the patient names someone to make decisions on their behalf if they lose capacity. This person can make choices in a variety of medical situations. Unlike a living will, this option is more flexible and can also be revoked if the patient regains the ability to decide. And finally, a do not resuscitate order, or DNR, tells doctors not to perform CPR if the patient's heart stops or they stop breathing. But it's important to note that the patient might still want other life-sustaining treatments, like a feeding tube, intubation, or even chemotherapy. Ventilator-assisted life support. Ideally, discussions with patients should take place before ventilator support becomes necessary, but in many cases, when the time comes, there may be no available information about what the patient would have wanted. In such situations, medical decisions often depend on surrogate decision-makers, whether they are identified by the patient or legally appointed. Now listen carefully, these discussions usually focus on the likely outcome of the condition, and more importantly, on what is believed to be the patient's own wishes. If the surrogate indicates that the patient would not have wanted life support with a ventilator, then life support should be withheld or withdrawn, regardless of the surrogate's personal preferences. You should remember this: if such a decision is made, it's essential to involve palliative care, chaplain services, and the primary care physician. Together, they should guide the medical discussions with the family, and offer emotional support during this difficult time. Now let's talk about the surrogate decision-maker. If a patient loses decision-making capacity and does not have an advance directive, then someone close to the patient, known as a surrogate, must decide what the patient would have wanted. The order of priority goes like this: first, the spouse, then adult children, followed by parents, then adult siblings, and finally, other relatives. And yes, sometimes the spouse plays a crucial role, or as we might say, chips in. Now listen carefully to the principles of confidentiality. Confidentiality is about respecting a patient's privacy and autonomy. But when the patient is incapacitated, or the situation is urgent, a physician must use professional judgment to decide whether sharing information with family or friends is in the patient's best interest. A patient can also waive confidentiality voluntarily, for example, to fulfill an insurance request. Are you following me? There are certain conditions where breaking confidentiality is not just allowed, but necessary. These are based on three key ideas: first, that the physical harm to self or others is serious and imminent; second, that there are no other reasonable means to protect those at risk; and third, that steps can actually be taken to prevent harm. Now let's go over a few examples, and here's a helpful way to remember them: the physician's good judgment saved the day. That means we break confidentiality in cases of suicidal or homicidal ideation, abuse of children, elderly, or prisoners, a duty to protect potential victims, as allowed by certain state laws, epilepsy, or other conditions that impair driving. And reportable diseases, like sexually transmitted infections, hepatitis, or food poisoning, where physicians may be required to notify public officials, who then inform those at risk. And for dangerous communicable diseases like tuberculosis or Ebola, treatment may even be given involuntarily. Now let's move on to a sensitive topic: accepting gifts from patients. This is complex, with no strict rules. Some believe that small gifts can strengthen the patient-physician relationship, while others worry about unintended negative consequences. In real life, patients often offer things like cards, homemade food, or inexpensive items. So how should a physician respond? Well, the physician must consider whether the gift could cause harm. Are you ready? They should not accept gifts that are too large or too valuable, or if the gift might interfere with medical judgment, or if it might cause emotional or financial stress for the patient. If any of these conditions are met, the best approach is to thank the patient sincerely, express appreciation for the kind gesture, but gently explain that the gift cannot be accepted. And most importantly, it must be made clear that this decision in no way affects the physician-patient relationship. Communication skills. Now let's talk about patient-centered interviewing techniques. To begin, always introduce yourself, ask the patient their name, and how they would like to be addressed. Address the patient by the name and pronouns they give you, and avoid making gender assumptions. Sit at eye level, near the patient, and face them directly. Then, move into agenda setting, identify the patient's concerns, and set goals by developing a joint agenda between you and the patient. As you continue, engage in reflection by actively listening and synthesizing the information offered, especially the primary concern or concerns. Validation is next. This means legitimizing or affirming the patient's perspectives. Recapitulation follows, and here you summarize what the patient has said so far, making sure you've understood them correctly. Don't forget facilitation. Encourage the patient to speak freely, without guiding their responses or using leading questions, and always allow them to ask questions throughout the encounter. Now listen carefully, because next we're establishing rapport, using a helpful tool called pearls. First, partnership. Work together with the patient to identify their primary concerns and create solutions they prefer. Then show empathy by acknowledging their emotions and demonstrating that you understand why they feel that way. If needed, make an apology and take personal responsibility. Show respect by commending the patient for discussing their problem, enduring hardship, maintaining a good attitude, or anything else constructive. Then comes legitimization, which means assuring the patient that their emotional responses are common or understandable. Finally, offer support by reassuring them that you'll work together through difficult times and by offering the right resources. Now we're going to talk about something especially important, delivering bad news using the spikes method. Start with the setting, offer in advance for the patient to bring someone for support, eliminate distractions, ensure privacy, and sit down with them to talk. Then move to perception, determine what the patient already understands and expects. Next is invitation, get their permission to share the news, and ask how much detail they want. For knowledge, share the information slowly, in small parts, without medical jargon, giving them time to process, and check their understanding as you go. When emotions arise, and they will, acknowledge those emotions, allow them to express how they feel, and offer empathetic responses. And lastly, under strategy, if they feel ready, talk about treatment options and goals of care, suggest an agenda for the next visit, and give them some control. It can be empowering. Ask them how they would solve the problem, and what they'd like to do moving forward. Now let's talk about gender and sexuality inclusive history taking, and listen carefully because it's important to avoid making assumptions about sexual orientation, gender identity, gender expression, and behavior. For example, a patient who identifies as heterosexual may engage in same-sex sexual activity. Use gender-neutral terms when referring to the patient or the patient's family, for example, partner, rather than husband or wife, upon first meeting the patient, until the patient instructs otherwise or uses specific pronouns. A patient's assigned sex at birth and gender identity may differ, and you should not bring up gender or sexuality if it is not relevant to the visit, for example, a gender-nonconforming patient seeking care for a hand laceration. Consider stating what pronouns you use when you introduce yourself, for example, I'm Dr. Smith, and I use she/her pronouns, and ask patients how they would like to be addressed. Also, consider ways of being inclusive, for example, ensuring correct name and pronouns are in the electronic medical record. Reassure them about the confidentiality of their visits, and be sensitive to the fact that patients may not be open about their sexual orientation or gender identity to others in their life. Remember, trust is built over time, and listening to and learning from patients about how they would like to approach the topics discussed above is key. Now let's talk about the cultural formulation interview, and remember, it's important to identify the problem through the patient's perspective. Ask the patient to describe the problem in their own words, or how the patient would describe the problem to their family and friends. Identify cultural perceptions of factors leading to a problem, and ask the patient to explain why they think they are experiencing their problem. Then, identify how the patient's background influences their problem, and ask the patient about what makes their problem better or worse. Investigate the roles of family, community, and spirituality. Identify how culture may impact current and future interventions, and ask the patient if they have any concerns or suggestions about the current plan of treatment. If they do not want to follow medical advice, investigate if there is a way to combine their plans with the standard medical regimen. Identify possible barriers to care based on culture, and ask the patient if there is anything that would prevent them from seeking care in a standard medical institution. Probe for explanations, and explore what may increase the chance of maintaining a good patient-physician relationship. Now listen carefully, because we're moving on to motivational interviewing, which is a counseling technique to facilitate behavior modification by helping patients resolve ambivalence about change. It is useful for many conditions, for example, nicotine dependence or obesity, and is especially helpful when the patient has some desire to change, but it does not require that the patient be committed to making the change. It may involve asking patients to examine how their behavior interferes with their life, or why they might want to change it. Assess barriers, for example, food access or untreated trauma, that may make behavior change difficult. Assessing a patient's readiness for change is also important for guiding physician-suggested goals. These goals should be specific, measurable, achievable, relevant, and time-bound, SMART. And now, let's not forget trauma-informed care. Patients with history of psychological trauma should receive thorough behavioral health screenings. Regularly assess mood, substance use, social supports, and suicide risk. Focus assessments on trauma-related symptoms that interfere with social and occupational function. Always be empathetic, and do not ask invasive questions requiring the patient to describe trauma in detail. Ask permission prior to discussion. Before the physical exam, reassure patients that they may signal to end it immediately if they experience too much physical or emotional discomfort. Offer the presence of additional staff for support. Psychological counseling may be indicated, and follow-up counseling is offered or advised as appropriate. Remember the 4 R's: realize, recognize, respond, and resist re-traumatization. Now let's talk about what makes the most appropriate response in clinical settings, and you should remember, the most appropriate response is usually one that is patient-centered, open-ended, and empathetic, and one that acknowledges the obstacles in care, and validates emotions. It often honors one or more of the principles of autonomy, beneficence, non-maleficence, and justice. Appropriate responses are respectful of patients and other members of the healthcare team. So always consider the patient's point of view. Now listen carefully, because we're going to explore some situation-specific examples. If a patient does not follow the medical plan, determine whether there are financial, logistical, or other obstacles preventing the patient's adherence. Do not coerce the patient into adhering or refer the patient to another physician. Instead, schedule regular follow-up visits to track patient progress. If a patient desires an unnecessary procedure, attempt to understand why the patient wants the procedure and address the underlying concerns. Do not refuse to see the patient or refer them elsewhere, and avoid performing unnecessary procedures. When a patient has difficulty taking medications, determine what factors are involved in the patient's difficulties. If comprehension or memory are issues, then use techniques such as providing written instructions, using the teach-back method, or simplifying treatment regimens. Now let's talk about confidentiality and communication with families. When family members ask for information about the patient's prognosis, avoid discussing issues with relatives without the patient's permission. And if a patient's family member asks you not to disclose the results of a test if the prognosis is poor because they believe the patient will be unable to handle it, explore why the family member believes this would be detrimental, including possible cultural factors. Explain that if the patient would like to know information concerning care, it will not be withheld. However, if you believe the patient might seriously harm self or others if informed, you may invoke therapeutic privilege and withhold the information. Now, if a 17-year-old is pregnant and requests an abortion, remember that many states require parental notification or consent for minors. Unless there are specific medical risks associated with pregnancy, a physician should not sway the patient's decision for or against an elective abortion, regardless of the patient's age or fetal condition. Discuss options for terminating the pregnancy and refer to abortion care if needed. If a 15-year-old is pregnant and wants to raise the child, but the patient's parents want you to tell her to give the child up for adoption, remember that the patient retains the right to make decisions regarding the child, even if the patient's parents disagree. Provide information to the teenager about the practical aspects of caring for a baby, and discuss options for terminating the pregnancy if requested. Encourage discussion between the patient and parents to reach the best decision. Now listen carefully, because the final situations deal with sensitive or emotional topics. If a terminally ill patient requests physician-assisted dying, remember that the overwhelming majority of states prohibit most forms of physician-assisted dying. However, physicians may prescribe medically appropriate analgesics even if they potentially shorten the patient's life. If the patient is suicidal, assess the seriousness of the threat, and if the patient is actively suicidal with a plan, suggest remaining in the hospital voluntarily. The patient may be hospitalized involuntarily if needed. If a patient states that you are attractive and asks if you would go on a date, use a chaperone if necessary, and remember that romantic relationships with patients are never appropriate. Set firm professional boundaries with direct communication, and transition care to another physician if necessary. If a woman who had a mastectomy says she now feels ugly, find out why the patient feels this way. Do not offer falsely reassuring statements like, "You still look good." If the patient is angry about the long time spent in the waiting room, acknowledge the patient's anger, but do not take it personally. Thank the patient for being patient, and apologize for any inconvenience, while staying away from efforts to explain the delay. And finally, if a patient is upset with treatment received from another physician, suggest that the patient speak directly to that physician regarding the concern. If the problem is with a member of the office staff, reassure the patient you will speak to that person. Let's continue about ethical responses in challenging clinical situations, and remember, your role as a physician requires honesty, compassion, and clarity. If an invasive test is performed on the wrong patient, regardless of the outcome, a physician is ethically obligated to inform the patient that a mistake has been made. And if a patient requires a treatment not covered by insurance, you must discuss all treatment options with the patient, even if some are not covered by their insurance companies, and be sure to inform the patient of financial assistance programs. Now, consider this scenario: a 7-year-old boy loses a sister to cancer and now feels responsible. At ages 5 to 7, children begin to understand that death is permanent, and all life functions end completely at death, and everything that is alive eventually dies. Provide a direct and concrete description of his sister's death, avoid clichés and euphemisms, and reassure the boy that he is not responsible. Also, identify and normalize his fears and feelings, and encourage play and healthy coping behaviors, like remembering her in his own way. Now listen carefully, because these next cases involve safety, autonomy, and trust. If a patient is a victim of intimate partner violence, ask if the patient is safe, and help devise an emergency plan if there isn't one. Ask direct, open-ended questions about exam findings, and summarize the patient's answers back to them. Always ask if the patient has any questions. But do not necessarily pressure the patient to leave a partner or disclose the incident to the authorities, unless required by state law. Now, if a patient wants to try alternative or holistic medicine, explore any underlying reasons in a supportive and non-judgmental manner. Advise the patient of known benefits and risks of treatment, including adverse effects, contraindications, and medication interactions, and consider referral to an appropriate complementary or alternative medicine provider. If a physician colleague presents to work impaired, this presents a potential risk to patient safety, and you have an ethical and usually legal obligation to report impaired colleagues so they can cease patient care and receive assistance. Seek guidance in reporting, since procedures and laws vary by institution and state. Are you following me? Because now we'll talk about more sensitive ethical issues. If a patient's family insists on maintaining life support after brain death has occurred, citing patient's movements when touched, gently explain to the family that there is no chance of recovery, and that brain death is equivalent to death. Let them know that movement is due to spinal arc reflex and is not voluntary, and bring the case to the appropriate ethics board regarding futility of care and withdrawal of life support. If a pharmaceutical company offers you a sponsorship in exchange for advertising its new drug, you must reject this offer. Generally, decline gifts and sponsorships to avoid any conflict of interest. The AMA Code of Ethics does allow exceptions for gifts that directly benefit patients, special funding for medical education, and grants distributed by independent criteria without sponsor attribution. Now, if a patient requests a non-emergent procedure that is against your personal or religious beliefs, provide accurate and unbiased information so the patient can make an informed decision. In a neutral and non-judgmental manner, explain that you do not perform the procedure, but offer to refer the patient to another physician. If a mother and her 15-year-old daughter are unresponsive and bleeding heavily, and the father refuses transfusion because they are Jehovah's Witnesses, transfuse the daughter, but do not transfuse the mother. Emergent care can be refused by the healthcare proxy for an adult when preferences are known or inferred, but not for a minor based only on faith. You should remember this next part closely. If a dependent patient presents with injuries inconsistent with the caretaker's story, document a detailed history and physical exam. If possible and appropriate, interview the patient alone, and provide all necessary medical care. If suspicion remains, contact appropriate agencies such as Child or Adult Protective Services for evaluation, and inform the caretaker of your obligation to report. Physicians are required by law to report any reasonable suspicion of abuse, neglect, or endangerment. Lastly, if a pediatrician recommends standard vaccinations for a patient, but the child's parent refuses, address any concerns the parent has, and explain the risks and benefits of vaccination and why they are recommended. However, do not administer routine vaccinations without the parent's consent. Now let's talk about communicating with patients who have disabilities, and this begins with respect, awareness, and adaptability. Patients may identify with person-first language, like a person with a disability, or identity-first language, like a disabled person. You should always ask patients what terms they prefer. Under most circumstances, speak directly to the patient, and do not assume that nonverbal patients are unable to understand. Caregivers who accompany them can certainly add information when needed, but the patient remains your main focus. Ask if assistance is desired, instead of assuming the patient cannot do something alone. Most people, including those with disabilities, deeply value their independence, and it is important to support that. Now listen carefully, because communication techniques matter. For patients with speech difficulties, provide extra time during the interview, and if their speech is hard to understand, you can consider asking them to write a few words or rephrase their sentence. Repeat what they said back to them to make sure you understood correctly. For patients with cognitive impairment, use language that is concrete and specific, and ask simple and direct questions. Try to eliminate distractions and background noise, and do not assume that the patient can read. You should always adjust your communication to match how the patient understands best, which may include using hand gestures or asking them to demonstrate a task. Are you following me? Because now we'll cover another important group. For patients who are deaf or hard of hearing, ask them what their preferred mode of communication is. You can use a light touch or wave to get their attention. And for those who prefer to speak and lip read, remove background noise, face the patient directly, and do not change your way of speaking. When necessary, consider using an interpreter. And as with any part of the medical history, do not bring up a disability if it is irrelevant to the visit, for example, if a patient in a wheelchair comes in with an ear infection. Also, do not skip important parts of the physical exam, even if the disability makes it more difficult to perform. Now let's talk about the use of interpreters, because language access is critical for quality care. When seeing a patient who speaks little English, you should use a professionally trained medical interpreter unless you are conversationally fluent in the patient's preferred language. If no interpreter is available in person, interpretation can also be done by phone or video call. If the patient prefers using a family member, make sure to document that preference in the chart. And remember, never assume that a patient is a poor English speaker based on their name, skin tone, or accent. Always ask what language the patient prefers. You should remember this next point about interpreter presence and engagement. The physician should always make eye contact with the patient and speak to them directly. Do not speak in the third person with phrases like, "tell him." Allow extra time for the interview and ask just one question at a time. For spoken language interpretation in person, the interpreter should ideally be positioned next to or just behind the patient. For sign language interpretation, the interpreter should be next to or just behind the physician. And finally, in emergency situations, communication should be facilitated with any tools available, like friends, family, sketches, or interpreter apps, even though these are not considered standard procedure in normal situations. Now let's talk about disease prevention, and how it's categorized into 4 levels: primary, secondary, tertiary, and quaternary prevention. Primary prevention aims to prevent disease onset by reducing risk factors or increasing immunity. This is directed at the general or susceptible population. For example, promoting a healthy diet and regular exercise to prevent diabetes is a form of primary prevention. Now listen carefully. Secondary prevention is all about screening for early detection and initiating treatment for pre-symptomatic disease. This targets individuals in the subclinical or asymptomatic phase. For instance, glucose screening for type 2 diabetes mellitus is a good example. It's done before symptoms appear to catch the disease early and take action. Are you following me? Because now we're moving to tertiary prevention, which focuses on treating symptomatic disease and preventing its progression. This is aimed at individuals already experiencing clinical symptoms. An example would be using hemoglobin A1C monitoring to guide diabetes treatment and prevent complications, morbidity, mortality, and disability. And finally, you should remember this: quaternary prevention focuses on avoiding unnecessary medical interventions and preventing iatrogenic harm. This applies especially to symptomatic patients who are over-medicalized or whose conditions are not treatable. One example is discontinuing a sulfonylurea after a patient experiences multiple hypoglycemic events. The goal here is to prevent overtreatment and to do no harm. Now let's switch gears and talk about major types of medical insurance plans. These include EPO, HMO, POS, PPO, ACO, and HDHP, and each comes with its own features, limitations, and cost considerations. An exclusive provider organization, or EPO, requires in-network care but does offer out-of-network coverage if there's an emergency. A health maintenance organization, or HMO, usually comes with lower premiums and out-of-pocket costs, but it limits you to in-network providers and requires a referral from your primary care doctor to see a specialist. A point-of-service plan, or POS, combines elements of both HMO and PPO plans. It allows you to access out-of-network care, but at a higher cost, and still requires a referral for specialists. A preferred provider organization, or PPO, offers more flexibility. You can use in-network or out-of-network providers, and there is no referral requirement, but out-of-network care will cost more. You should remember this too: an accountable care organization, or ACO, is a group of healthcare providers who voluntarily coordinate patient care, specifically for Medicare patients. And finally, a high-deductible health plan, or HDHP, offers low premiums but higher out-of-pocket costs. These are compatible with health savings accounts, known as HSAs. Now, let's talk about healthcare payment models. In a bundled payment system, the healthcare organization receives a fixed amount per service, no matter the actual cost, and this amount is divided among all providers and facilities involved. Capitation is another model where physicians get a set amount per patient assigned to them during a specific time period, regardless of how much care the patient uses, and this is commonly used by some HMOs. Next, we have discounted fee-for-service, where the insurer or patient pays for each service individually but at a pre-negotiated discounted rate, often seen in PPOs. Then there's the traditional fee-for-service model, where payments are made for each service separately. Global payment is a bit different. Here, the insurer or patient makes a single payment covering all expenses tied to one incident of care, like elective surgeries, which includes pre- and postoperative visits. You should remember Medicare and Medicaid, which are federal social healthcare programs created through amendments to the Social Security Act. Medicare is for patients 65 or older, those under 65 with certain disabilities, and people with end-stage renal disease. Medicaid, on the other hand, is a joint federal and state program for those with limited income or resources. A helpful way to recall the difference is, Medicare is for the elderly, while Medicaid is for the disadvantaged. Now, let's break down Medicare's 4 parts. Part A covers hospital admissions, hospice, and skilled nursing. Part B handles basic medical bills like physician fees and diagnostic testing. Part C combines Parts A and B and is delivered by private companies. And Part D covers prescription drugs. Listen carefully when we discuss palliative care, which focuses on comfort, relieving suffering, and improving quality of life for patients with complex or life-threatening illnesses, regardless of their prognosis. It often runs alongside curative treatments and is provided by an interdisciplinary team in hospitals, clinics, or at home. Hospice care is a specific form of palliative care for patients with a prognosis of 6 months or less, when curative treatment is no longer desired or beneficial. Now, let's move to types of medical errors, which can involve patient identification, diagnosis, monitoring, infections, medications, procedures, devices, documentation, or handoffs. Errors should always be disclosed to patients, whether they cause harm or not. An active error happens at the front line, like programming the wrong 4 dose, and has an immediate impact. A latent error is more indirect, occurs in processes indirect from operator but impacts patient care, e.g., different types of intravenous pumps used within same hospital, and is essentially an accident waiting to happen. A never event is adverse event that is identifiable, serious, and usually preventable, e.g., scalpel retained in a surgical patient's abdomen. It is major error that should never occur. Sentinel event is a never event that causes death or severe harm. A near-miss unplanned event that does not result in harm but has the potential to do so, e.g., pharmacist recognizes a medication interaction and cancels the order. It is narrow prevention of harm that exposes dangers. Now, let's talk about medical error analysis and the design methods used to address these issues. Root cause analysis is a retrospective approach, meaning it's applied after a failure event to prevent it from happening again. This method uses records and participant interviews, like the 5 whys approach, fishbone or cause and effect diagrams, and process maps, to identify all the underlying problems that contributed to the error. These problems can involve processes, people, the environment, equipment, materials, or management. On the other hand, failure mode and effects analysis is a forward-looking approach, applied before a process is implemented to prevent failures from occurring in the first place. This method uses inductive reasoning to predict all the possible ways a process might fail and then prioritizes them based on how likely they are to happen and how severe their impact on patients could be. Now, shifting focus to the causes of medical errors, burnout is a major factor, which results from prolonged and excessive stress, leading to emotional exhaustion, depersonalization, and ultimately reduced professional efficacy. Another key cause is fatigue, which stems from sleep or rest deprivation and results in cognitive impairment and decreased attention to detail, both of which can contribute to mistakes in patient care.